Thank you everyone for coming and for your time this afternoon. Out of respect for those people who have been prompt, we will be starting in a moment. Good afternoon, my name is Marie-Louise Bird. I'm a clinician scientist who actively researches knowledge translation and health literacy to support health professionals in their ongoing development. I'm pleased today to be co-presentation scientist with a clinical background in occupational therapy. Lauren is one of the inaugural members of the Implementation Science Collaboration Sphere, which stands for the Sydney Partnerships for Health Education, Research and Enterprise, which is an NHMRC Advanced Implementation Science Translation Centre in New South Wales. The aim of today's presentation is to take a walk through commonly used knowledge translation strategies and reflect on how well they link to behaviour change in clinical practice. There are three parts. Firstly, I will briefly introduce the Tasmanian Collaboration for Health Improvement and then broadly speak about knowledge translation strategies and behaviour change. Then Lauren will present a fully fleshed out example using a theory-driven explanation of behaviour change application in practice. There's an opportunity for some questions at the end, so please post in the chat if you have questions. I'd like to thank the Tasmanian Collaboration for Health Improvement for facilitating and organising this presentation today. Today, I am in Lutruwita, Tasmania, the lands of the Palawa and Pakeha people, and Lauren resides in the lands of the Gweagal people of the Darawal Nation. The Tasmanian Collaboration for Health Improvement acknowledges the traditional custodians of the lands, seas and sky country and recognises the impact of colonisation on Tasmanian and other Aboriginal peoples and the legacy of health inequity that we are working to redress today, including through this collaboration. The Tasmanian Collaboration for Health Improvement is an emerging research translation centre and one of 14 centres within the whole of Australia. It brings together key stakeholders, including the Department of Health in the Tasmanian Government, the University of Tasmania, Health Consumers Tasmania and Primary Health Tasmania. We support clinicians and researchers in a number of ways by aligning research agendas and policy and evidence, supporting clinicians to develop research skills and contribute to research and implementation science. Researchers are supported through grant applications with knowledge translation plans and consumer involvement advice. And consumer involvement is at the heart of what the collaboration believes is vital for research at all stages. The collaboration hosts events such as this, promoting and sharing resources on their website, offering mentoring and networking opportunities, and supporting research translation and building the research capacity and capability of the health workforce in the state. There are now over 600 people who subscribe to the Tasmanian Collaboration for Health Improvement, and if you would like to join them, please contact Tichy Admin or use this QR code. Research generates knowledge that can be translated into health practice, and some health practice changes may include quality improvement projects, healthcare redesign, so that knowledge translation as a term can be broader or include a broader range of activities than research translation itself. The World Health Organization defines knowledge translation as the synthesis, exchange, and application of knowledge by relevant stakeholders to accelerate the benefits of global and local innovation in strengthening health systems and improving people's health. There are a number of other terms that are sometimes used interchangeably, and we need to recognise that some of these terms have evolved over time and they might mean different things to different people. But whatever you call it, the translation of knowledge generated in the lab or described in research journals or presented at conferences will only impact the health of our communities when it's put into the hands of people and organisations who can use it. While there are a number of different frameworks that describe behaviour and the reasons for what we do, why we do what we do, the behaviour change wheel is a framework for describing, designing, and evaluating behaviour change strategies. At its heart here in green is the COM-B model, which proposes that behaviour is an interaction between capability, opportunity, and motivation. It forms the centre of the behaviour change wheel, and this might be enough information for you to start doing some behaviour change activities. But if you want to delve deeper into this and explore some of the sub-elements, you can see that there are social, physical, psychological, emotional, and belief factors that can be important drivers for change. The strength of this framework is that it's linked here to the theoretical domains framework, which further drills down into 14 categories or behavioural elements. From this image, I'd like you to consider that there are a number of different levels of factors that may need to be considered. Some of these are personal attributes of the stakeholders involved, and some of them reflect the impact of interaction with other people, environments, and systems that can influence behaviour. Clinicians who are interested in practice change within their workplace may use frameworks like this to identify a desired practice change, determine the KT, knowledge translation, or implementation strategies that they will use and how they will evaluate it. This methodology is relevant equally across research and quality improvement processes that are already constantly underway within our health system. This is an example of an integrated knowledge translation approach, where the people who identify the problem are also the people who propose the system, who propose the solution and carry it out. Activities such as this benefit from planning. Knowledge translation planning requires several steps, and while knowledge translation can have a number of different goals, target a different number of audiences. For example, researchers sharing information with other researchers or clinicians, clinicians sharing information between each other or with clients. Our presentation today will focus on practice change for health professionals, and we will spend some time looking at linking relevant strategies depending on the goal or the way in which practice will need to change. And I acknowledge that these cards come from the KT game from Toronto. That is an interesting and fun way to increase knowledge about knowledge translation planning. So as I said, there are a number of different goals that knowledge translation can have, and these occur at multiple levels, depending on what knowledge is being translated and who to. And this can range from high-level policy or decision-making activities through to those that can increase adherence to guideline-based care or using evidence-based approach. We know that if our goal is to change clinician practice, then there are two levels of goals that may be relevant. Firstly, clinicians may not be aware of the new knowledge or information. So what we might need initially is a strategy to generate awareness or share knowledge. However, our research and those of many other people have indicated very strongly that education alone is not an effective in generating practice change. To do this, to get buy-in and change practice, a raft of other strategies that are relevant to the goal and the particular context are needed. Consideration of the local context of the audience, including both the people, the social and the physical environment that they're in, will be needed to tailor any strategies for successful implementation. In the next few slides, I present to you a range of KT strategies that you might like to consider when planning for a KT practice change. These are role-based strategies, and all of these rely on a person or people undertaking certain roles to support knowledge translation. As we'll see in a few slides' time, these people or role-based supports can also be used to support behaviour change. In fact, what I hope becomes evident through this presentation is that there's considerable overlap between the strategies for knowledge translation as the mechanism for practice change, as the mechanism for practice change depends on the same constructs. Here we can see having support from one or two people, like a champion or an opinion leader, or a number of people, like a community of practice, can support clinicians in implementing change in their workplace. Educational resources and the provision of information is vital to raise awareness of new knowledge. As I've mentioned, this is an important first step in generating practice change. However, as a standalone activity, is rarely successful in changing behaviour. However, educational resources are valuable for clinicians to support their knowledge and skill development as an important part of the capability portion of the COM-B. I also ask that you consider how they may be useful for fostering behaviour change in the clients that they are caring for. The advent of technology in clinical practice, including electronic medical records, provides a mechanism to remind people of the current evidence. An example would be when evidence provides changes to optimal medication management for a client population, and when this is established in the literature, then reminders in the medical record can be used to ensure that clinicians deliver appropriate medication and care. Recently, haptic nudging, or providing a vibratory stimulus through a device, has been used to remind clients to move more when they're in rehabilitation. The evidence for improved client outcomes with improved levels of physical activity while in rehabilitation is well established in the literature. However, how best to do this remains unknown, which is why implementation science strategies have much to offer our understanding in this space. A number of process-based strategies have been identified as improving client care and outcomes through providing ways of working, such as supporting health professionals to change their practice by working in multidisciplinary teams. And in my area of research that includes stroke research, this evidence is reinforced by the Australian Stroke Guidelines. From a recent systematic review that our team undertook, we evaluated the effectiveness of recently published interventions that implement evidence into stroke rehabilitation practice that focus on either clinician practice changes or patient outcomes. The role or person-based interventions that were included were multidisciplinary training and support, multi-professional collaborations, communities of practice, and opinion leaders. Educational opportunities included the provision of materials, educational outreach, or workshops that were delivered both in face-to-face and online formats. Monitoring and feedback, developing customised implementation plans, integrated care models, rapid rehabilitation pathways, tailoring to the local context, and payment incentives were all described, and one study used a policy brief. Technology was used to provide continuous communication between healthcare providers and their clients, comprehensive reminder systems, mobile apps, and haptic nudging. I've selected here a number of behaviour change techniques that link back to several levels of the behaviour change wheel, and would like to quickly look at how these behaviour change strategies that may be able to improve a health outcome, something we're all familiar with, may also be used to change clinician practice through changing health professional behaviours. For any of us who've wanted to change a behaviour, we know how having someone to support us while we do that can be an effective behaviour change strategy. The KT strategies that align with social support include communities of practice, opinion leaders, leadership within your organisation, or a champion who models behaviour change that is the target. The provision of information, education and training are well-established methods of improving awareness and may be an important step to behaviour change. Educational resources as a behaviour change strategy have been successfully used by clinicians to improve functional and nutritional practices in their clients. I know that if I want to go for a run, putting my running shoes out is an important step for embedding a new habit. In the same way, midwives who wanted to help their clients reduce smoking habits found that environmental redesign, that is, having nicotine replacement samples and prescriptions at hand, as well as a poster on the back of their door to remind them to deliver them, increased the number of opportunities for them to assist their clients to change their behaviour. Working in teams also improves client outcomes. The process of setting up a team forms part of this process-based approach. However, there's also overlap with strategies with the social support that the social support of working together may bring. I have a Fitbit watch. It gives me feedback about my heart rate, how many steps I've done, and monitors other aspects of my performance. That is a strategy that I use to try and meet the physical activity guidelines. In the same way, this behavioural strategy is seen in practice when clinicians undertake audits or audit and feedback cycles to better understand and evaluate practice change. Planning for practice change will lead to more successful and sustained changes, and I hope this presentation has started you all thinking about the overlap between knowledge translation strategies and behaviour change strategies that may be useful in supporting clinician behaviour change and client outcome. I'd like to hand over to Laura now, who will take us through a worked example of this. Thanks, Lauren.
Thanks so much, Marie-Louise. I'll just bring up my slides for everyone, and then we'll just go into presentation mode. Can you see that okay?
Just see you at the moment.
Okay, let's try that again then. Let's try and share once more. Got it now?
Yep.
Great. I can see
Yep.
Angela nodding, so that's fantastic. Thank you so much for the invitation to present today. As Marie-Louise mentioned, I am part of the Sphere Implementation Science Collaborative, which is part of one of the New South Wales Advanced Research Translation Centres. And today I'll be talking about some work that I undertook as part of my PhD. I'm now based as a Senior Research Fellow embedded within health, supporting allied health clinicians at St Vincent's Health Network in Sydney. And the work I'll be talking about today was undertaken in my previous role when I was based within Southwestern Sydney Local Health District, both of which are partner organisations within Sphere Advanced Translation Centre. So I'd just like to thank my co-authors as well as the supporters of the project, Southwestern Sydney Local Health District, the University of Sydney, where I completed my PhD, and the Ingham Institute of Applied Medical Research, who provided us with research support during this study. So as Marie-Louise has spoken about a little bit earlier today, there's a range of different implementation frameworks within the literature that are used, which can lead to quite a lot of confusion. There's some that focus on broader organisational components. There's some that focus more on the knowledge to action framework, for example, and that process of translating knowledge into practice. For the purposes of today's presentation, I'll be focusing though on just two of these models and how we applied them within our particular example, the Active Arm project. So I'll be focusing on the behaviour change wheel, which Marie-Louise has already spoken about briefly in her presentation, and how we use that model to design, our implementation strategy, and then how we evaluated our project, our overall implementation strategy using the RE-AIM framework. For those of you who are interested in the Behaviour Change Wheel and finding out more about it, they have an excellent online book that you can purchase. There's also the Behaviour Change taxonomy, which lists the various behaviour change techniques, some of which Marie-Louise has mentioned earlier. You can do some online training to help you to upskill in that if you are looking to do more implementation research. And I've just put a QR code to the online training there on the slide. We're happy to make these slides available after today's presentation. So the first step within an implementation project is to identify the problem. So what the issue is and the size of the issue. So for some context, my background is as a neurological occupational therapist, and I've worked predominantly in stroke and traumatic brain injury rehabilitation throughout my professional career. I have a really strong interest in upper limb rehabilitation, and we have one particular intervention in amongst that suite of therapies that we offer that's known as constraint-induced movement therapy. Now, this intervention was initially developed in the 1970s to overcome arm impairment after stroke, and it involves people completing quite an intensive boot camp style program for their affected upper limb, where they're doing multiple hours of practice per day that's gradually increased in terms of the level of challenge, generally for about a 2 to 3 week period. Throughout that time, they wear a mitt or some sort of other restraint on their non-affected hand to encourage as much use as possible of their affected arm in day-to-day activities. And they're also given a transfer package, which is a series of behavioural mechanisms that help support them to adhere to the program. There's regular check-ins from their treating therapist, and there's also a series of coaching and generalization techniques that are built into the transfer package to help the person move the things that they're working on in their structured therapy sessions into using their affected arm in their day-to-day life. Now, in terms of the evidence base for CIMT, we have a number of published systematic reviews that demonstrate that this is an effective intervention for improving arm impairment and upper limb activity and function after stroke. It is, in fact, the only upper limb intervention that we have that is listed as a strongly recommended intervention within our Australian living guidelines for stroke. I undertook this work at the time of our previous 2017 guidelines, but this strong recommendation remains to now. So if people have a little bit of active movement in their wrist and at least 2 of their fingers, that they should be being offered this evidence-based intervention. But we knew from audits that had been done nationally of our rehabilitation services in Australia that generally less than 12% of eligible stroke survivors were being offered this intervention as part of routine rehabilitation. So there was a really big practice gap that needed to be addressed. Now, at the time, I was working in a clinical role where I was embedded within the brain injury rehabilitation service at Liverpool Hospital, which is based in southwestern Sydney Local Health District. For those of you who might not be familiar, southwestern Sydney Local Health District is one of the largest health districts in New South Wales. We have significant cultural diversity in southwestern Sydney, and we also have 14 of the 20 most disadvantaged suburbs fall within our local health district. Now, that's important because at the time we were looking at this, constraint-induced movement therapy was primarily offered via private practitioners at a significant out-of-pocket cost to stroke survivors. This was pre-NDIS, so people were paying for programs privately at between $5,000 and $10,000 out of pocket for a 2-week program. And I was working in a local health district where people simply couldn't afford that to be able to access an evidence-based intervention that they should be being offered routinely. I'd previously worked in a private hospital in the UK where I'd been able to offer this intervention much more regularly, and I'd seen the improvements that people could make when they had access to this program. So I was very passionate about identifying ways that we might be able to embed this within our usual care across southwestern Sydney. So the Active Arm project had a number of aims and research, one key aim, but a number of research questions rather, and it was to investigate the impact of an implementation package on clinician behaviour change and whether we could increase the number of CIMT programs that were offered over a 2-year period within our local health districts. We wanted to see if the teams offered this intervention more routinely after they'd received a particular implementation strategy or support package, which I'll describe more in a moment. And then what was the impact of that for stroke survivors and people with brain injury? If they did receive a CIMT program, did they achieve upper limb outcomes that we would expect based on what's been published within the number of clinical trials? We wanted to look at whether teams could recruit enough people to continually offer this intervention. And we also wanted to analyse what the costs and cost effectiveness was of delivering CIMT and district-wide implementation. So first of all, we had to identify how big the practice gap was. And so we did a series of file audits as part of this process. We had 9 neurological rehabilitation teams who were recruited to the study across 5 different hospitals in the local health district. And they were working across a range of settings, everything from acute stroke units through to inpatient rehabilitation, both specialist neuro rehab and mixed rehab units, as well as some outpatient and community-based rehab services. We aim to look at least 20 files per team at each of the file audit time points that I'll discuss in today's presentation. You can see for some services we were a little bit short, so we ended up just under the 180 at this baseline time point. But overall, you can see that we had, in terms of looking at the information that was available in the file, we had at that baseline time point, it was over 30% of people were eligible for CIMT, but we had less than 2% that were offered a program. So that showed us that we had a really significant practice gap. For those 2 people, the less than 2% who had been delivered a CIMT program, further detailed review of the clinical notes indicated that even though the therapists had documented they'd received CIMT, programs had been delivered that were missing some of those core components that I'd talked about at the start of the presentation, suggesting that these programs, even when they were delivered, weren't being delivered with fidelity. So we then had to determine, well, what are the barriers and enablers to practice change? Why aren't people currently offering CIMT? And then select some behaviour change strategies to develop our implementation package to target those specific barriers and enhance the enablers to support them to change their practice. So this forms one of the studies in the Active Arm program of research where we're focusing on the development of our behaviour change intervention. And this was targeted at occupational therapists, physiotherapists and allied health assistants in those 9 teams. And all of the publications I'll be sharing today are open access. So I've included QR codes if you'd like to go and have a further read later on. So after completing our baseline audits, we then conducted a series of focus groups and one-to-one interviews with each of the teams to identify the barriers and enablers to delivering CIMT. We then analysed those transcripts and mapped the barriers and enablers to the theoretical domains framework, which is that more granular level of the COM-B that Marie-Louise mentioned earlier. It includes 14 domains that have been identified to influence behaviour and has been validated for use in behaviour change and implementation research, and has been used very extensively in other clinician and health professional behaviour change projects. We then used the behaviour change wheel processes to assist us in developing our behaviour change intervention. So in terms of the outcomes that we found from our focus groups in terms of the barriers, we found that there was barriers in relation to knowledge. So whilst clinicians knew about CIMT, they often didn't know all the core components, and they didn't know the how-to of how to deliver a program. Now, linked with this lack of knowledge, there was a lack of confidence or beliefs about capabilities. So people said, I wouldn't know how to get a program set up and get started. That makes me feel very nervous. And as a consequence, they then avoided offering it as an intervention. Many of the teams also identified a range of resource-related barriers, such as insufficient time and how it might have an impact on other competing demands within busy clinical environments. Some of the key enablers, though, there was a number of them, which was great to see, was that occupational therapy and physiotherapy already in that particular local health district had a strong history of working collaboratively to deliver upper limb therapy. So they had a history of a shared model of care, which was great, which meant that there might be opportunities to share some of the workload for this intensive intervention to make it more feasible in busy public health contexts. They were also really concerned about not only that they weren't delivering evidence-based interventions and what the potential impact was both for patients and their long-term outcomes, but also in relation to their performance on the National Stroke Guidelines. They were also optimistic that they would be able to deliver CIMT programs after they'd had some further training, and that they had some transferable skills from their existing expertise in delivering upper limb rehabilitation. They identified, though, what was really important was that they were going to have to work together as a team, OT and physio working together with the support of allied health assistants to come up with a model of CIMT delivery that fit within their local context and resources. It's important for me to point out at this point in time, none of the teams were given any additional staffing. This was a true implementation project where we were focused on supporting teams to deliver this within usual care with existing resources. So after our mapping process, which is outlined in detail in that publication, if you'd like to know more about that, we then designed this behaviour change intervention or implementation strategy that was a multi-component implementation strategy. As Marie-Louise has already mentioned, we know that delivering education is important, but that education alone is often insufficient for clinicians to change their behaviour. And as CIMT is a complex intervention, and with a number of those other barriers that have been raised, we knew we had to address this using a multi-prong approach. So we did that by designing this implementation strategy that included regular audit and feedback to teams about their practice every 3 months, about who had come through their service, who was eligible for, offered and delivered a CIMT program. We did deliver a series of 2-day training workshops to increase knowledge, skills and confidence. And that included a strong practical component where we had stroke survivor volunteers coming in the afternoon sessions to allow the clinicians an opportunity to apply the skills and knowledge that they'd been learning in the morning sessions. Social supports was also very important. We established an online monthly teleconference community of practice, and each of the 9 teams nominated a local CIMT champion or 2 who would dial into those meetings, and the teams would then share any ongoing challenges with implementing CIMT in their practice and share ideas and resources that they developed along the way to help support getting CIMT up and running. We also did some environmental restructuring, as Marie-Louise had mentioned. All of the teams were provided with a series of CIMT work booklets to make it easy for them to just grab the resources that they needed off the shelf and get a CIMT program started. We also had 2 series of reminder posters. One was put up in clinician offices, encouraging them to consider CIMT in their treatment planning, and the other was targeted at patients and put up in gym areas and other clinical spaces, encouraging them to ask if they were eligible for CIMT. Then for each of the teams, as a final component of social support, we did some drop-in face-to-face support during their first CIMT program only. We then had to move towards evaluating the outcomes associated with our behaviour change intervention. And so this study then focused on looking at whether our purpose-designed multimodal behaviour change intervention resulted in therapist behaviour change and increased how many people were offered and delivered a CIMT program. Now, for this component of the study, we used the RE-AIM framework, which has 5 components. It's a really excellent framework and useful for evaluating health services programs and their effectiveness. For the purposes of today's presentation and time, I'll just focus on the primary and one of the secondary outcomes. The primary outcome being adoption, so looking at whether rehabilitation teams delivered more CIMT programs after they'd received our CIMT behaviour change intervention package. And finally, if participants did receive CIMT, did they achieve upper limb outcomes consistent with what we would expect from the published literature? So this was a mixed method study. As mentioned, we had our baseline audit feedback cycles that I mentioned at the beginning. We actually did 3 lots of those. We then did a series of focus group interviews, designed our behaviour change intervention, and delivered it. So once that started, we then did an audit and feedback cycles every 3 months with each of the 9 teams, looking at how many people in their service were eligible for, offered, and delivered a CIMT program. When people had received CIMT within their usual care, we then sought their permission to share their CIMT workbook data and their routinely collected outcome measures. That continued for an 18-month period, after which we conducted post-implementation focus groups to find out a little bit more about sustainability of practice change, and then withdrew our research team support. And 6 months later, did one final round of file audits to see if teams had been able to sustain the practice after we had withdrawn those training workshops, community of practice, and regular audit and feedback cycles. So these are the outcomes. You can see myself and the team looked at over 1,500 files over the course of the project, which was a lot of auditing. But you can see here we have those numbers where we have less than 2% of eligible people being offered CIMT and delivered a program at that baseline time points. You can see that we have that here in the blue line is how many people received a program, and the bars are representing how many eligible people, or the proportion of eligible people rather, that were offered a program. You can see in around March of 2017, we delivered our behaviour change intervention. So we ran our series of 2-day training workshops, provided the teams with all of their written resources and posters, and commenced the community of practice. And within that quarter, there was an immediate improvement in the proportion of eligible people who were offered and then delivered a CIMT program. Those proportions continued to improve, where by the end of the 18-month period, where CIMT by that point was far more embedded across these 9 teams, we had just under 80% of eligible people being offered a program and almost 50% of eligible people receiving a program. Now, of course, we've still got a way to go in terms of improvement, but just for those of you who are familiar with the implementation science literature, you would have read before that around a 15% change in practice is considered quite a positive outcome. So we were very happy to see this significant improvement across those time points. When we then did a final evaluation 6 months after withdrawing our support, those changes had been maintained. So whilst there was a bit of a drop in the proportion that were offered, the change wasn't statistically significant, and the proportion of people who had received a CIMT program remained relatively stable. If we then have a look at the outcomes associated, this is from a sample of 74 stroke survivors who agreed to offering their outcome data from their CIMT programs. The Action Research Arm test is a measure of arm function. The box and block test is a measure of dexterity. And then the Canadian Occupational Performance Measure measures in relation to person-centred goals, their self-perceived performance and satisfaction with that. And the Motor Activity Log measures amount of use and quality of movement across 30 activities of daily living and is a self-report measure of arm use and quality of movement. So if you have a look at the outcomes here, people have achieved a clinically significant improvement across all of those outcome measures, pre to post intervention. We then did 1 month follow-up where you can see that those changes have been maintained. And in fact, with the box and block test, people actually made even further improvements. For the Canadian Occupational Performance Measure, a 2-point change would be considered the minimal clinically important difference. So we've seen some significant improvements there, as well as on the Motor Activity Log, where the minimal clinically important difference is 1 point. So fantastic to see that effective translation resulting in improved patient outcomes. We then wanted to investigate the cost and cost effectiveness of this behaviour change intervention implementation support package and what the costs were associated with delivering this intervention. So I'll go through this rather briefly, but for our active arm economic evaluation, we wanted to compare our implementation package plus therapist time using a bottom-up approach, their CIMT program hours, and we modelled that against no implementation package and what the mean amount of upper limb therapy was per week. And this is based off some other observational data that had been conducted by Angela Vratsits-Curto, who was conducted her research at one of our participating sites, one of the 5 hospitals. So it was a good comparator for our economic model. We then looked at the cost effectiveness using incremental cost effectiveness ratios. At the base case here, you can see that it's quite expensive, it would appear, to deliver a CIMT program, around $8,000 for an individual program, $6,000 for a group per cost per person, gaining meaningful change in their Action Research Arm test. When we then adjust that and conduct a one-way sensitivity analysis, we then can see some changes. So if it's embedded within usual care, it drops to $1,505 per additional person, gaining meaningful improvement. We then looked at it in a multi-component best case scenario. Now, within this scenario, we looked at a scale up of our implementation package, and we didn't include any therapist resource costs, considering that CIMT was embedded within usual care, with clinicians delivering this routinely and stopping other non-evidence-based interventions. And then in the best case scenario, that came to just $245, suggesting that this intervention would be a good value for money if it was embedded within usual care and used routinely, and if our implementation package was scaled up. Finally, I'll just briefly cover that we also explored the experiences of people who received a CIMT program as part of ActiveArm, and then used the COM-B model in another way, this time to look at how that supported people's adherence to a CIMT program. As you can imagine, being an intensive boot camp style program, one of the key barriers that's often reported within the literature that's been studied extensively, what are the barriers to CIMT delivery? Therapists will often report it's patient-related factors, concerns that patients wouldn't be able to tolerate the intensive program, that they would be too fatigued, that people aren't interested in engaging in a program of this nature. But what's been really interesting is that when we started this work, very few studied had actually asked stroke survivors about what their thoughts were and experiences were of completing a CIMT program. So we thought it was important to explore what that experience was like for stroke survivors and what were the factors that helped them to adhere to this intensive upper limb program. So we did interviews with 45 CIMT participants 1 month after their CIMT program. We used an inductive approach to thematic analysis to identify initial themes and codes, and those codes then were mapped back using a deductive approach to those 3 elements of the COM-B model: capabilities, opportunity, and motivation, to identify what the barriers and enablers were that supported them to adhere to their CIMT program. And I've kept these very brief because I knew we'd be tight on time today. But in terms of capability, there were elements around the physical requirements of the program, people talking about that they did experience some fatigue and the importance of using strategies and tailoring programs to help support people to be able to maintain the level of physical skill that's required for task performance. Social support was really, really important for people who completed a program. So having the ongoing encouragement and coaching that they received from their therapy team, but also support and encouragement from family members was really beneficial. What was very interesting as well is that a number of the participants spoke about the value of doing a CIMT program in that it filled the time. We've have a number of observational studies in stroke now that show that whilst clinicians are incredibly busy, stroke survivors spend long periods of the day sitting alone on their own on the ward, not engaging in meaningful activity. So that was just interesting that we have this perception that it would be too intense, and yet the stroke survivors and people with brain injury are saying it was actually a really helpful way to feel like they were doing activities that helped to support their recovery and also help to reduce boredom. People reported that they were motivated to do programs because of the incremental increase in the level of challenge, that they could often see small regular improvements in their arm function. And so whilst it was really hard, they seeing those improvements kept them motivated. And they also spoke about the importance of sticking at it, that the program was often most challenging within the first 3 days or so, and then they were able to develop more of a routine that helped to support them to see it through to the 2-week completion. So in terms of implications and future research directions, we were able to address a really important evidence practice gap. We did identify, though, which you will see if you go and have a read of the evaluation of ActiveArm, that ongoing support, though, is needed for sustainability of CIMT in practice and overall practice change, which is consistent with the broader literature. Teams spoke about the importance of having access to ongoing booster training sessions, that there would be benefit to ongoing use of the community of practice and file audits cycles, but maybe at a lesser intensity. But to keep it front of mind and as opportunities to upskill new staff members with the high level of turnover that we experience within public health. What was really essential in this particular case with an intensive, complex intervention was the use of interdisciplinary models of care. All of our teams had OT and physio working collaboratively in different mixes. Each of the teams selected a model of CIMT delivery that worked within their local resources and context, back to that importance of tailoring to the local context that Marie-Louise mentioned at the beginning. But being able to work together so that the burden of this intervention didn't sit solely with one person was another really critical element for supporting sustainability of practice change. You would have noticed from our results that there was ongoing discrepancies in the proportion of people who were offered versus delivered CIMT, and we're exploring that further now in a study I'm involved with, where we're using a discrete choice experiment design to look at people's preferences for how CIMT programs are delivered. Unfortunately, because we were using file audit data to collect that information retrospectively, you'd often have very brief information, offered CIMT, patient declined. And so what would be really interesting as well would be to be a fly on the wall to hear some of those conversations, because I think the way in which the intervention is presented and that stroke survivors are educated could play a really important role. We're also currently exploring some alternative models of CIMT delivery via telehealth, which may have the potential to improve cost effectiveness. And we've also highlighted that it's very important that stroke survivors need ongoing social support to help them with those coaching and encouragement to adhere to a CIMT program. So this is just to mention briefly, we're currently finalising. We've run over the course of COVID, building on our lessons that we've learnt from Active Arm. I've worked collaboratively with some colleagues from the UK and New Zealand to develop a suite of online resources to support clinicians to deliver CIMT via telehealth. And we're currently evaluating the effectiveness of that as part of the ReSite study, which has been supported by the Australian Stroke Foundation and St Vincent's Multidisciplinary Clinic Foundation, one of our philanthropic arms. And they're just my contact details if you'd like further information, but I'm happy to share my slides. And I'll just stop sharing now and hand back to Marie-Louise for any questions.
I note that we're getting close to the end of time, and I can't see that we've got any questions in the chat. Vic, can you let us know if there's anything that that you'd like us to talk about? And I will, hopefully I can see, if people would like to post something in the chat now, please let us know. I've got a thanks from Sharon. Thanks for coming, Sharon. So please post a question if you've got, there you go.
There's nothing additional to add. Thank you. So there's currently an item in the chat, curious for the reference for 15% change in practice being significant.
Mm-hmm. And that, I mean, I'll get Marie-Louise can speak to it as well, but that goes back to some of the work. I can't remember the specific reference, but I remember it's some of the work that's been done by Jeremy Grimshaw and colleagues, and that it's really hard to get practice change. And so aiming for perfect is probably not very feasible. I know even within trying to improve our performance on specific guideline recommendations within our Australian clinical stroke registry, they use a particular technique to work out, based off the best performing hospital and the worst performing hospital, they have a formula for working out what's a feasible amount of practice change to expect for a service within a 1-year period. So I hope that addresses some of your questions, Nadia. I think it's remembering that behaviour change and implementation science is about trying to move our health service in the right direction. There will always be some ongoing challenges or some people who are very resistive to change. And so it's about trying to just shift the dial that little bit. Do I have a sense of what my implementation study would have cost? I can tell you, Angela, that the study was awarded around $330,000 through the New South Wales Health Translational Research Grant Scheme. That's what was awarded to support that study.
I will point,
a lot of work in for that amount of money, just as a kind of side note.
And I will point out that that does include the evaluation as well. So if you were doing it as a health service, it wouldn't actually cost that much. But I think it is really important to indicate that we do identify that there are evidence to practice gaps, but it actually is really difficult to shift. And so anything that we can do to shift it in the right direction, I think is a really positive goal to do. And as I think I said in my presentation, how we do it, like knowing how to do it, that's what implementation science is, and we're still working on that. It's a relatively new field.
Yeah. I was just going to, just whilst you're looking at the questions there, Marie-Louise, I think that that's a really important point, is if just to take away from today is that really make sure that it's avoiding that Isla Giat principle of it seemed like a good idea at the time and just jumping in with a solution. What we'd really encourage you to do is use some of these frameworks and take a very systematic approach to identifying what the gap is, what are the barriers and enablers to why it's not currently happening, and then use that to inform the design of your implementation strategy, rather than just kind of coming up with ideas that seem like they might be a good fit. Because if you don't do that really thorough behavioral diagnosis, you might actually be suggesting strategies that aren't addressing the right part of the problem.
Yeah, thanks. And I think that comes back to that notion of really planning before you go. Vic, are you able to unmute Sharon?
I can unmute.
Oh, okay. You go then.
You sort of already answered a little bit of my question, but I suppose I was thinking, for people who are clinicians, this is clearly a very big project and there's been a lot of work that's gone into it. And so I'm wondering what sort of guidance you might give to people who don't have, you know, a really big grant, but are still identifying issues clinically that require some sort of work, whether it's with the COM-B or another model. So just wondering, you know, what sort of take-home messages you might provide to those people.
Yeah, I mean, I guess a couple of really important points. One is I did this project part-time while still working in a clinical role. So I was doing my clinical job 3 days a week and active 2 days a week. So can completely appreciate and empathize with the challenges of applying this within your clinical real world setting. And just an important point back to the funding that we received was for the research, for the evaluation of this, not for the health, I guess, the health teams so much. So, but for the COM-B, you can, everything that we've talked about today, you can scale it down and do it at the level of just your team, your ward. The COM-B now has some really helpful resources. There's a COM-B validated short questionnaire that you can download as an open access publication, which is just made up of 8 questions, which then gives you and you just drop in your intervention of interest. And then you can use that to start to identify, well, where are our gaps according to the COM-B? And there's lots of really helpful resources online now as well that show you that, right, if I've got gaps in, say, knowledge, the things that are most likely to help are elements such as education, use of reminders, and skills training, for example. If there's issues in relation to people remembering to do a particular activity, maybe we need some more reminders in the environment. So there's lots of resources online that can help you with that. So yeah, the COM-B validated 8 questionnaire would be a good place to start.
Nada's asked for a link to that. We might see if we can get that to you later. I'd just like to reinforce what Lauren said, and also the value of having like an integrated knowledge translation approach where the people who identify the problem also work on identifying the solution. And the whole notion, and Lauren shared the CIFA, the consolidated implementation framework, which really drills down into local context and local barriers and facilitators. So what might work for one group won't work for another group. So it's actually about having that shared vision of, we actually want to do better. You know, what is the thing that we want to target, and really start small would be my advice. You know, what's the one thing that you can do? And it often comes back to, we don't actually know, are we delivering the best care? And start with some basic monitoring or chart audits to actually look at how much you're delivering care, because really there might be something that needs changing and there might be something that doesn't actually need changing. There would be a better target for your team. And I'll just finish with saying something that Lauren said that really resonated with me, with people working in the health system who are really tired, really burnt out, who turn up and work hard, really hard every day. But the notion that they can change things, stop doing things that don't work, start doing things that are potentially more effective, actually the personal satisfaction that they actually are making a difference like that, I think is that one thing that really does engage people in a time when people are feeling really overwhelmed and burnt out.
Yeah, I think that's such an important point, Marie-Louise. No one comes to work with the intention of doing the wrong thing. You know, I think particularly in health, people come to work really wanting to do a good job. And I think that's important to always have that front of mind too when we're thinking about how we design implementation strategies as well. And just really reinforcing what Marie-Louise said around local context is really important. Within our study, that was the 9 teams picking a model of CIMT delivery that fit for their local service. So it didn't look the same between the brain injury inpatient unit and brain injury outpatients or the acute stroke unit in the same hospital. It's about making, you know, those overarching principles of, we need these elements of the intervention, but how that fits within our context, our service, that can be tailored to what works for us.
So more listening, less telling, I think. I'm going to close off there because we're out of time. I'm sorry, I think there's one question we didn't address around implementation and demographics. And I'm not sure that there is evidence that younger people adopt digital things more easily. I'm not sure of any evidence on that, Lauren. I think there's lots of factors there.
Yeah, the one thing I would say just briefly on digital things though, my colleague Reem Rendell, who was one of the co-investigators on Active Arm though, has recently published a fantastic systematic review looking at behaviour change elements in apps to support neurological people with neurological conditions with their goals, and that often many of the apps are missing those behaviour change techniques. So I would encourage you all to go and have a look at that, because I think if you have an interest in app design or tech to be used to help support behaviour change, integrating those features and working with a behavioural scientist is really important.
Thank you so much, Lauren. It's been a great session.
Thank you.